So good morning, everyone. Thank you for joining us. We will be talking about ASH 2024 updates today, and I'm privileged to co-host this session with Dr. Shen from UT Southwestern, as well as Dr. Ibrahim Ibrahim from UT Southwestern. I'm also faculty at UT Southwestern. So I will be starting the session, and I will be primarily covering the aplastic anemia and PNH. And then Dr. Shen will be covering bleeding disorders, thrombosis, and Dr. Ibrahim will be covering the ITP as well as the sickle cell important trial. And so again, we have 6 abstracts for aplastic anemia and 2 abstracts for PNH. These are all oral abstracts. So the first one is the L-Thrombopac added to standard immunosuppressive treatment improves long-term outcomes as frontline therapy for severe aplastic anemia. This is an update 2-year analysis from EBMT group. So as we know, horse ATG cyclosporin L-Thrombopac has been the standard first-line treatment since 2018, and there has been phase 2 trial from NHLBI as well as phase 3 trial from EBMT group. And as we know, there has been many attempts to increase the complete response or overall response in aplastic anemia patients by adding different immunosuppressions to horse ATG cyclosporin, and not any particular one worked up until the L-Thrombopac addition to standard immunosuppression, horse ATG cyclosporin. L-Thrombopac combination made a huge difference when they reported back in 2022 on New England paper. That was a phase 3 trial, and 6 months overall response rate was around 70%. And so the question is, does adding L-Thrombopac to standard IST improve hematological responses? And also, does it make any difference in terms of survival outcomes among the aplastic anemia patients? Let's remember the RACE trial. It was a prospective randomized multicenter trial, horse ATG cyclosporin with L-Thrombopac. They included severe and very severe aplastic anemia patient populations. They stratified to horse ATG cyclosporin versus horse ATG cyclosporin L-Thrombopac, and they started the L-Thrombopac on day 14 and until 6 months or 3 months in case of early CR. So as we remember, this is also this is an update actually, the 100 patient stratified for each arm, and the complete response was higher on the triple group versus the doublet group. And when they looked up to overall response, it was 52% on triple group and 36% on the horse ATG cyclosporin arm. And there was less treatment failure on the triple therapy arm compared to the double arm, the horse ATG cyclosporin arm. And then when they looked up the multivariate analysis, as you can see here, age made the difference. Less than 40 was higher response rate, and severe patient did better than the very severe patients. And then when they looked up the fatal cases, there were less fatal cases on the triple arm, the L-Thrombopac arm, compared to the horse ATG cyclosporin arm. Then the 2-year overall survival was 91% in arm B versus 86% on arm A, and 2-year disease-free survival on arm A was 36% and on arm B was 54%. On multivariable analysis, the effect of the L-Thrombopac varied in time with the hazard ratio of 0.5 on average across the 2-year period, being significant only in the periods of 0 to 6 months and 6 to 12 months, but not at 12 months. Both age and disease severity affected the disease-free survival. The cumulative incidence of relapse was comparable in 2 arms, with 2-year estimate of 22% on arm B and 18% on arm A. and the risk of clonal evolution remained negligible. Just one patient on the arm A and 2 patients on the arm B. And the 2-year cumulative incidence of clinical PNH was 1% on arm B, which was the horse ATG cyclosporin L-Trombopac, versus 8% on arm A with a significant hazard ratio. So that was a little surprise to see less PNH on L-Trombopac combination group. So they concluded L-Trombopac, horse ATG, and cyclosporin provides a significantly higher hematological response rates versus horse ATG cyclosporin alone, even at 24 months. This effect is more evident on CR at 24 months. Also, the EFS and DFS at 2 years are significantly superior in EPOC horse ATG cyclosporin over horse ATG cyclosporin alone, whereas the overall survival was a little better on the triple therapy, but not statistically significant. No significant difference in ISC discontinuation, relapse, and malignant clone evolution. Only clinical PNH appeared less frequent in L-Trombopac arm, and this supported the notion of using this combination as standard of care based on this 2-year data from the phase 3 trial. So we will move to second study that was a longitudinal contribution of distinct hematopoietic clones during marrow recovery in immune aplastic anemia that was presented by NHLBI group Fernandez Rodriguez. As we know, severe aplastic anemia is an immune-mediated marrow failure characterized by pancytopenia and depletion of hematopoietic stem and progenitor cells by the cytotoxic T cells. The clonal hematopoiesis has been reported in nearly 70% of aplastic anemia cases, mainly including somatic mutation of PGA, BCOR, BCOR-L1, ASXL1, and DNMT3A. So the question has been how these clones relate to disease pathophysiology, recovery post-immunosuppression, and evolution to myeloid neoplasm is poorly understood. So for that, question was raised was what distinct clonal dynamics underlie marrow recovery in immune aplastic anemia, and how do specific clones contribute over time? So to understand this, the NHLBI group mapped the trajectories of somatic mutation from onset to over 11 years of follow-up to assess the hematopoietic stem cell contributions throughout the disease course of severe aplastic anemia in patients treated with horse ATG cyclosporin and L-Trombopac. So the median age was 32, ranged from 3 to 82. And at baseline, as you can see here, 64% of patients had clonal hematopoiesis, mainly PGA mutation, DNMT3A, BCOR, ASXL1, and with the median VAF less than 2%, and 25% of them did have multiple mutations in these genes, and only the DNMT3A clonal hematopoiesis was age-related. So post-IST, after the 6 months of being exposed to ISTs, 71% of cases showed clonal hematopoiesis, increased from 64, and new mutations were mostly in BCOR and ASXL1. The pre-existing BCOR mutation and ASXL1 clones expanded on average 7.5 to 3.5 fold respectively, unrelated to 6 months hematological response. In contrast, the DNMT3A and PGA variants were stable. So when they looked up the longitudinal clonal dynamics, it was different after 6 months. Most BCOR clones disappeared, as you can see here, or were present at very low levels post-IST, regardless of marked expansion at 6 months. When co-occurring, a decreasing of BCOR clones coincided with the late expansion of ASXL1 clones. Most PGA and ASXL1s detected pre or post-IST persistent during follow-up, regardless of IST response. And in half of the cases, ASXL1 clones expanded to more than 10% VAF, a few co-occurring with the novel somatic mutations in MDS-related genes. So they concluded the clonal profile dominated by PGA, BCOR, and ASXL1 mutation is likely associated with the underlying immune-mediated pathophysiology, while the NMT3A is age-related, and HSPCs with clonal hematopoiesis, BCOR and ASXL1 are a major contributors to hematopoiesis during marrow regeneration. Long-term ASXL1 trajectories are consistent with linear acquisition of pre-malignant mutations that precede late secondary myeloid neoplasm. So we will move to third study that was presented by UK group by Austin, the dynamics of oligoclonal hematopoiesis in severe aplastic anemia. Very similar work what was presented by Fernanda Rodriguez from NHLBI, slightly different from the patient phenotype and larger cohort of patients up to 2 years of follow-up. So we will be talking about the dynamics of this clonal architecture. So as we discussed, the EBMT race trial was the phase 3 trial that showed the superiority of the L-Thrombopac with horse ATG and cyclosporin in comparison to standard IST alone. And we know the clonal hematopoiesis has been reported up to 60-70% even at baseline, but we don't really understood in the field what is the clinical significance of this clonal hematopoiesis. So to shed light on that unknown entity, they mapped their own trial patients, and as you can see here, initially 197 patient enrolled on both arms, and 170 of the patient had the genetic samples, and also at 24 months they had 103 patients who had the genetic workup. So the somatic mutation were assessed at diagnosis and sequentially 6 and 24 months following the IST, and they captured as low as 0.2% VAFs, and 141 patients analyzed at both baseline as well as 6 months, while around 90% analyzed at all 3 time points. So at baseline, as you can see here, 30% had the clonal hematopoiesis, lower than what NHLBI group reported, and older age and less severe disease has higher somatic mutational burden at baseline. Baseline mutation did not correlate with treatment response at 6 months. At 6 months and 24 months, around 55% of the patients had the clonal hematopoiesis, and 80%, 79% on the 24 months. In patients with mutations, the median mutation rates were 1.4 at baseline, 2.2 at 6 months, and 3.1 at 24 months. There was also a trend of median VAF increase, variant allele frequency increase, from baseline to 6 months, with no significant difference in treatment arms. So when they looked up the particular mutations, PKA, DNMT3A, BCOR, BCOR-L1, TET2, ASXL1 were the most frequently mutated genes. The median age of patients with PKA, BCOR, and BCOR-L1 was lower than the patient with other mutations, especially ASXL1 and TET2. The NMT3A and TET2 mutations occurred more frequently in older patients, and new ASXL1, BCOR, and PKA mutations tend to emerge in between at baseline and 6 months at the early time points. And the number of PKA mutations increased over time significantly on arm A, which was the horse ATG cyclosporin arm, compared to the arm B, both at 6 months as well as at 24 months. And there were higher incidence of hemolytic PNH in the standard IST arm, non-EPAC arm. So they concluded somatic mutations are more frequent in aplastic anemia, with increase over the disease course. Baseline mutations correlated with older age and less severe disease, but impact was lost during the 6 months and 24 months. No correlation with treatment arm or hematological response. Dominance of PKA mutation is less severe disease, and more evident on standard IST arm at 6 months with evolution to clinical PNH. And then new emerging mutations not associated with age or disease severity or response. And complex hematopoietic differentiation patterns with acquisition of multiple clones of variable allele burden with likely persistence for larger clone. So we will move to another interesting provocative study that was presented by Nazia Mato from King's College using the autologous regulatory T cells for refractory aplastic anemia patients. This was so before we will go to trial, regulatory T cells are reduced in both severe and non-severe aplastic anemias. It has been demonstrated that Tregs in aplastic anemia are in a naive resting state and can be expanded in vitro with the presence of IL-2. Additionally, studies have shown that expanded Tregs are suppressive and polyclonal with capable of preventing GvHD in mouse models. So the question has been, can expanded regulatory T cells safely modulate the immune response and restore marrow function in aplastic anemia? So this was the first in human phase 1 trial of expanded autologous Tregs in aplastic anemia. They included patients ineligible for transplantation or failed immunosuppressive therapy. The trial designs included 2 doses of expanded Tregs administered 2 weeks apart, and they enrolled 6 very old age aplastic anemia refractory populations. So the Tregs were successfully expanded from all 6 patients. Half of them was severe aplastic anemia patients, and their age was from 68 to 79 years, and all of them completed this 2 dose of infusion. 2 patients responded. 1 transfusion-dependent patient became transfusion-independent with platelet increase, and another patient also showed improvement with platelet count and achieved red cell transfusion independency. So they summarized Tregs from aplastic anemia patient can be expanded in vitro to large numbers. 2 doses of expanded Tregs are safe and did not associate with the cytokine release syndrome. And 2 patients after infusion of 2 doses expanded Tregs responded. So we will be moving to another study that was presented by Australian group, Zoe McKilton from Diamond Investigators, and they proposed to use avatrombopag in combination with horse ATG cyclosporin in treatment-naive aplastic anemia population. So just to remind all of us, avatrombopag is another second-generation TPO receptor agonist, and is approved for chronic ITP. It does bind the same transmembrane domain as the L-trombopag, does not compete for endogenous TPO, and not being evaluated in the clinical trial with the benefit of not being affected by food intake or the hepatic impairment. So the question is, does adding avatrombopag to IST in first-line treatment improve hematological responses and patient outcomes among severe aplastic anemia patients? So they had the aim of assessing the efficacy and safety of avatrombopag in treatment-naive patients, and basically they included the same patient population as the RACE trial, severe and very severe aplastic anemia patient, no prior ATG-based immunosuppressions, and they gave the horse ATG 40 milligram, the same as the RACE trial, and cyclosporin for a year, then tapered. And the dose they used for avatrombopag initially was 20 milligram. Later, they made some revision and they treated with the 60 milligram of avatrombopag from day 1 up until, I believe, up until 6 months. So you can see the primary outcome was similar to RACE trial, and they enrolled eventually 49 patients. And you can see the characteristics of patients. Some of them did have some PNH clone, as well as evenly distributed severe, mainly severe patient enrolled to this trial. And when they looked up the CR, you can see here, 65% had CR at 6 months, with partial response was around 31%. And then when they compared to race trial, as you can see here, the race trial was the EBMT trial, phase 3 trial. As you can see here, the overall response was quite similar. And they concluded by proposing this agent to be another TPO mimetics to be used in the treatment-naive settings. Although I think we need to wait for the avatrombopag adverse event report. I think the manuscript, peer-reviewed manuscript, will be important before making any changes, especially in the United States. So this is another trial that also using another TPO mimetic to addition to horse ATG cyclosporin, and what was done in China and presented by Fengyu Zhang. So just to remind, heterombopag is another TPO receptor agonist, very similar to eltrombopag, and has been shown to be as beneficial, as effective as the eltrombopag in the mouse models, and it's been approved in China in 2021 since for the immune thrombocytopenia and severe aplastic anemia. So this was the phase 3 trial, and they reported their hematologic response to be 41% back in their phase 2 trial, and this was the first 2 trial. So does addition of heterombopag to standard IST improve the hematologic response and among the treatment-naive severe aplastic anemia patients? So they stratified the patients to 2 arms, as you can see here. They administered heterombopag 15 milligram daily for 6 months, and then the other arm received the horse ATG cyclosporin. The ATG they administered was mainly porcine and the rabbit ATGs. And then when they looked up the overall response as well as the CR, as you can see here, it was statistically significant, as 61% overall response on the triple arm versus 42%. And there was also rapidity of hematological response on the triple arm. And transfusion independent was also higher on the triple arm, and there was no major safety report that was observed. So they concluded this finding support the heterombopag as an effective and safe therapy for severe aplastic anemia, ineligible for transplant. Addition of heterombopag to IST resulted higher hematologic response, and the time to first hematologic response was faster in the triple group, and there was no unexpected safety signal. So I will be moving to last 2 presentation that was given. The first one was given by Christophe Patrigon regarding the efficacy and safety of pozalimab plus cemdisiran versus ravulizumab in PNH patients that is naive to complement inhibition. So pozalimab is a monoclonal antibody, and cemdisiran is an RNA interference therapeutics, and this is basically binds to C5 on the circulation, the pozalimab, and the cemdisiran reduces the production of C5 in the liver. So as we know, there are multiple complement inhibitors and regulators now. So the question is, does the combination of pozalimab and cemdisiran provide sustained terminal inhibition with favorable safety profile compared to ravulizumab? So this was the endpoint was controlling the LDH from baseline, and they had several other secondary endpoints, including hemolysis control and transfusion avoidance. So they administered this, stratified the patients, and this was the 26 weeks data report. And this medication was given every 4 weeks versus ravulizumab every 8 weeks. And it was evenly distributed among the arm. When they looked up the benefit of pozalimab plus cemdisiran, it was controlling the LDH slightly higher than the ravulizumab. And also when they switched from ravulizumab to pozalimab cemdisiran, some of them, minority of them, also had better LDH control, and there was no major adverse event. And the transfusion-wise, 56% became transfusion independent on the pozalimab cemdisiran group versus 65% on the ravulizumab group. So it was a little bit lower than the ravulizumab. So they concluded this pozalimab cemdisiran led to uninterrupted inhibition of terminal complement and control of intravascular hemolysis in the majority of patients. And it was meaningful control of IVH that when they compared to ravulizumab, but it was very slightly. But the benefit of transfusion independence was not really achieved. So I think we need more data to see if this will hold its position as a complement inhibitor for PNH patients, especially with the transfusion independence. So I will be moving to last study. This is a genetic determinants of hypercoagulability in complement and hemostatic system shaped the thrombotic risk of PNH. So this was presented by Carlos from Cleveland Clinic Group. So as we know, the CR1 polymorphisms and C5 variants, as well as some rare complement factor H variants, seem to impact the response to anti-complement therapies. Clone size, especially granulocyte and red cell, and some lab parameters with the PGA clonal burden has been shown to be a predictor of thromboembolic event. That was shown by the Cleveland Clinic Group back in 2020, I mean, on their publication 2024. But we don't know if the genetic variants trigger or amplify the complement cascade, can exacerbate PNH severity, or if there is any signal that is increasing the thromboembolic risk. So they hypothesized that germline variant in both complement and hemostatic genes associated with hypercoagulability aggravate the phenotype of PNH with a focused risk of thromboembolic disease. They performed sequencing-based analyses in 109 aplastic PNH patients. They screened low-frequency variants in 32 complement and 5 thrombophilia genes. These are not standard genes that we are able to test, but they did further testing on them, and they identified 15 low-frequency complement and 13 thrombophilia variants. Then they investigated the clinical impact of these variants, and when they combined the CR1, CHF risk alleles and complement variants, seemed overall more frequent hemolytic PNH. And complement, as we know, and the complement hemostatic genetic burden positively correlated with plasma levels of D-dimer, supporting increased hypercoagulability. And then genetic thrombophilia seemed to also increase in recurrent thromboembolic based on the D-dimer. And then when they did the multivariable analyses adjusted by sex, age, and clone size, the complement and hemostatic genetic burden was confirmed as an independent predictor of thromboembolism. So they concluded genetic determinants of variability in the complement and hemostatic system shaped the severity and thrombotic risk of PNH. And this was the first time that she reported to be the thromboembolic risk. And then risk alleles and low frequency variants triggering or amplifying this cascade seem to have additive effects on the PNH clone, causing more severe phenotype, leading to treatment failure or increasing the risk of thromboembolism. So I will stop here and I will give Dr. Shen for his session.
Okay, so sorry, there are a lot of slides to go through, so I'm not going to be as detailed as Taha. We'll just look at the results of each study. So the first part of the first section is on hemophilia, bleeding disorders. So this first study is assessment of annual rate changes in intra-articular tissue measurement in hemophilic joint experiencing acute bleeding using the Joint Activity Damage Exam, or JADE, ultrasound protocol. And so as we all know, joint bleeding is common amongst hemophilia patients, and there are different ways to assess the joint status. And so clinically, there's something called the Hemophilia Joint Health Score, or HJHS. And then with the ultrasound, one common protocol that folks who do point of care ultrasound in hemophilia patients is to use the JADE protocol. And so to determine the effect of acute joint bleeding on annual rate changes of JADE measurements was the aim of this particular study. So the hypothesis was that because of how good we are in terms of recommending prophylaxis to patients with severe hemophilia, uh, joint bleeding has become rare. And so this may not actually have a significant impact on the trajectory of joint health. And so the study showed that there was a low annual rate of bleeding as expected with prophylaxis, with effective prophylaxis. So on the study, they only had 16 bleeding into 16 joints. Um, and there were other bleeds too that actually were more common. So when they looked at the HS score, that actually remained stable over the study period. Um, and and they also found that there was no significant difference in the rate of change of the JADE measurements between bleeding and non-bleeding joints. And so it seems that because joint bleeding is actually rare, this actually it does appears to not affect the trajectory of joint health in adult patients with hemophilia who are well controlled on prophylaxis. And so this basically just reinforces the idea, the importance of prophylaxis in maintaining joint health. All right. So the next study is on the cost comparison of using EFA or Altuviiio with existing factor VIII replacement therapies for major surgeries in people with severe hemophilia. And so as many of you know by now, Altuviiio is a extended half-life factor VIII product with a half-life of 45 to 48 hours. And it's able to maintain a higher factor VIII level for the first few days after infusion. And the way it achieves that is by attaching a fragment of von Willebrand factor to a lactate, and therefore preventing the binding of this new molecule to the endogenous von Willebrand factor, which was thought to be the reason why there's a ceiling on the half-life of the extended half-life products previously. And because the factor VIII level stays up higher for a longer period, it would make sense to use Altuviiio in patients undergoing major surgery or other invasive procedures, because you may just need one infusion, maybe two infusions to cover the postoperative factor VIII requirement. So you can see the WFH recommendations in terms of target factor VIII levels in the post-operative period. So basically, by using standard half-life factor VIII infusions, you're going to need multiple infusions to achieve this. While using Altuviiio, theoretically, we could get away with one or maybe two infusions, and therefore lead to a cost saving. And so this is actually what was shown on this study. So Altuviiio versus Advate, there was a savings of nearly $80,000. Altuviiio versus Adynovate, the savings was nearly 64, was just a little over $64,000. And compared to Olactate, which is the molecule from which Altuviiio was derived from, there was a savings of more than $37,000. So as you know, Adynovate and Elactate are both considered extended half-life products. but the half-life is only about 18 hours or so for both of those products, versus the 48 hours of Altuviiio. And so this study basically proves the idea that using a single infusion of Altuviiio for surgical procedures, we could actually save money um, with our patients. And some of that probably come from not just the decreased factor usage, but also the less need for home health infusions, etc. Okay. So the next study is on emicizumab and immune tolerance induction. So I chose to present this one too because there was a clinical question that came up from one of our colleagues at UT Southwestern with in terms of doing ITI, immune tolerance induction, in a severe hemophiliac patient, severe congenital factor VIII deficient patient with inhibitor. Who's on emicizumab. And so this is a study, one of the studies to look at that particular issue. So as you know, emicizumab is approved for both patients with inhibitors or without inhibitors in congenital factor VIII deficiency. But the previous to emicizumab, the goal of treatment in patients with inhibitor is to eradicate the inhibitor. And that's done through immune tolerance induction. And now that we're achieving hemostasis with emicizumab, is it safe to do both? And so essentially, this study showed that there was no safety concern or thromboembolic events reported when emicizumab was used in combination with immune tolerance induction. There was one patient who achieved partial ITS success, 5 achieved negative inhibitor status, and they were all 5 of them were already on ITI prior to starting emicizumab. And so this is an ongoing study to further evaluate the safety of emicizumab during and after ITI. All right, so this idea of doing ITI alone at the same time as using emicizumab seems to be a reasonable approach according to this one small study. So this is another Japanese study looking at how emicizumab had impact on the quality of life with severe hemophilia A patients without inhibitors. And so it's a prospective multi-center observational study, and essentially just looking at physical activity and the bleeding events and quality of life scores in patients with severe hemophilia A and receiving emicizumab. And so what the study showed was that because these patients were taking emicizumab, they were able to engage in various exercises, including high-risk activities, with a low bleeding risk. And there was an improvement in activity levels, exercise frequency, motivation, and reduced bleeding anxiety. And what they found was that the quality of life measures approached that of Japanese national standards. And there were no new safety signals found on this particular study. And so this essentially shows what we kind of already know, that patients receiving emicizumab seems to have a better quality of life, and they're better able to enjoy life, so to speak. So this next one is to compare the risk of thrombotic events in older patients with hemophilia A on emicizumab prophylaxis to non-emicizumab products. And so that, because of what emicizumab does in terms of being a factor VIII mimetic, there's some concern that in certain patient populations, there may be an increase in thrombotic risk, especially in maybe the older patients. And so this particular study compared the thrombotic event risk in patients older than 50, at least 50 years old, with severe or moderately severe hemophilia A, while on emicizumab prophylaxis versus those who are not on emicizumab. And so what they found on this study was that cumulative probability of thrombotic event was 0.156 on emicizumab, and it was lower at 0.043 off of emicizumab. And the unadjusted hazard ratio was 2.65, which was non-significantly increased. When they adjusted the hazard ratio to whether the patient had prior factor A prophylaxis or not, it was 2.54, but again, not significant. And when adjusted to age at baseline, it was 1.95, again, not significant. And when adjusted to whether the patient has cardiovascular risk factors, this was again increased, but not statistically significant. And so it seems that numerically, patients on emicizumab may have an increase in the thrombotic event rate, but at least on this study, it was not determined to be statistically significant. All right, so this next one is looking at one of the newer agents that we have for hemophilia, both hemophilia A and B. So this is concizumab. And as you may already know, this is FDA approved recently, and it's an anti-TFPI monoclonal antibody administered once daily subcutaneously. And so this is looking at annualized bleeding rates in patients with hemophilia A or B, and inhibitors with or without inhibitors, with target joints at baseline. With or without target joints at baseline. And so they're looking at whether concizumab will reduce the annual bleeding rate. So you can see the doses of and the different treatment arms. And what they essentially found was that concizumab prophylaxis effectively reduces ABR in hemophilia A patients with inhibitor and as well as hemophilia B patients with inhibitor, regardless of baseline target joint status. So I misspoke earlier. This study only looked at patients with inhibitors, not without inhibitors. And those patients tend to have a higher rate of bleeding, even with prophylaxis. And that was significantly improved with the use of emicizumab, but we're now seeing this also with concizumab treatment. And so the low ABR, the annualized bleeding rate, was maintained at 56 weeks. All right, so this next study is on a novel agent that is being developed in China. So this is a snake venom enzyme. It activates factor 10. So it's purified from this snake, Baboia rossoli siamensis, and it's one of the components of the venom from this snake. So it's being developed as a hemostatic agent for hemophilia A patients with inhibitor and hemophilia B patients with inhibitor. So these are the doses. This is, I think, a phase 2 study. So they found that effective hemostasis was achieved in 96% of patients in 199 bleeding event rate. Um, and with the higher dose, with the lower dose, the effective hemostasis rate was 94% in 135 bleeding events. There were 4 patients in the higher dose arm or cohort that experienced grade 1 asymptomatic venous thromboembolism. By asymptomatic, it wasn't specified in the abstract. By asymptomatic, I assume that they were doing screening ultrasounds, and so they picked up a few clots from these screening ultrasounds. And anyway, so this drug called betotenase alpha demonstrates strong therapeutic effect and reasonably good safety. So, but they're going to have to work out the doses in terms of whether they could avoid the thrombotic risk in these patients. All right, so this next one is looking at what our team has been looking at in terms of osteoporosis, increased risk of osteoporosis in hemophilia patients. And there's been basically increasing evidence out there that show that in patients with severe hemophilia A and B, the risk of osteoporosis seems to be higher, and that seems to be a function of a decreased thrombin generation in these folks. And so this study is looking at head and neck femur fractures in a national inpatient sample. So they basically looked at a cohort of patients who presented to the hospital with head and neck femur fractures, looked to see whether the patients had hemophilia or not, and compared those with hemophilia to those without hemophilia. So only a small proportion of patients with head and neck femur fractures had hemophilia. I think it was around 5% or so, 5 or 6%. And hemophilia patients with the head and neck femur fractures were, on the whole, younger, and they had longer hospital stays and higher total charges, presumably because of the costs involved with providing hemostatic support. And because they were younger, they were less likely to have Medicare on this study. So this gives more credence to the idea that we should be, the Hemophilia Treatment Center should be screening for osteoporosis and intervene as these patients tend to have the osteoporotic femoral neck fractures at a younger age, and therefore potentially leading to more morbidity because of the fracture. All right, so this is looking at postpartum hemorrhage and hemophilia carriers, and so as you know, hemophilia carriers, their factor levels can sometimes be low enough to have an impact on their hemostasis due to lionization of the X chromosome. And so if they are identified with a relatively low factor level, we need to be monitoring for bleeding and intervening when they have procedures or when they deliver babies. And so this particular study was looking at whether targeting a higher level with giving prophylaxis at the time of delivery helped to alter the rate of postpartum hemorrhage. And so this is a Dutch study. And so in the Netherlands, in 2018, they revised their guidelines so that they want to they're targeting a higher third trimester factor 8 or factor 9 levels to 80 up from 50. And at delivery, they're targeting greater than 150. Previously, it was just greater than 100. And the goal is to mimic more physiologic Wolfram factor and factor 8 levels during childbirth. And so on this study, if the patients had factor 8 or factor 9 levels less than 80%, or IU per deciliter, they would provide prophylaxis with factor infusion. But if the factor 8 level was greater than 80 IU per deciliter, then only I think only 2% of the cohort received prophylaxis. And so they compared the rate of postpartum hemorrhage in these two groups. And it showed that they basically showed that like by giving when the factor 8 or factor 9 level was less than 80 and they were given prophylaxis, the rate of postpartum hemorrhage or incidence was similar to those with greater than 80 IU per deciliter factor level, but did not receive prophylaxis. We don't have information on the study on how high the factor level was achieved with the prophylaxis. So it remains to be seen whether by getting the factor level to greater than 150 was going to help with this postpartum hemorrhage incidence. So a further study is needed. All right, so the next section is on thrombocytopenia. I think I'm gonna, since Ibrahim is gonna cover ITP, I'm just gonna skip over this so that because of time. I know that we didn't overlap, but just for the interest of time, let's move on to the thrombosis section. So VTE, this first study is looking at VTE in sickle cell patients. And so we already know that sickle cell patients are at higher risk for having thromboembolic disease. So this study was to look at the prevalence of VTE and to investigate whether there are risk factors or laboratory findings that would predict for increased risk of VTE. So what they showed was that obesity is significantly associated with VTE in sickle cell patients. Smoking is also significantly associated with VTE. Having a central venous catheter, which is a no-brainer, is also associated with having VTE. And recurrence is common. So 33.4% with prior VTE experienced recurrence during the study, and 31% of those with VTE during the study experienced a subsequent event on the study. So recurrence is a fairly common problem, and which lends credence to the idea that we should consider long-term secondary prophylaxis with patients when sickle cell patients experience a VTE. And the next study is looking at cancer-associated VTE. So this is a comprehensive national study to analyze VTE incidence in a large cohort of cancer patients and looking specifically at cancer subtype, gender, and race. And so the study showed that 5.1% of cancer patients in the study experienced an acute VTE event. It was higher in the VT was more common, slightly more common amongst females, and there was a racial disparity. It was most commonly found observed in Black patients, more than followed by white, followed by Native Americans and Hispanics, and the Asians had the lowest risk, where it was least common in Asians. And it was more commonly found in solid tumors compared to liquid tumors. And amongst the solid tumors, GI tumors was most common, followed by lung. So 28 and 25, almost 26%, respectively. Amongst the hematologic malignancies, non-Hodgkin's lymphoma made up 42% of the VTE cases. So this gives us a better idea of which patient groups to consider prophylaxis in. So this next study is looking at cancer patients and looking for modifiable risk factors for anticoagulant-related bleeding. So we know that cancer patients with clots on anticoagulation seems to have a higher risk of bleeding because of the anticoagulant use. And so this study was to quantify the proportion of anticoagulant-related bleeding attributable to modifiable risk factors using population attributable fraction, or PAF. And so they identified on this study alcohol abuse was a risk factor. Anemia with hemoglobin of less than 10 was also a risk factor. Patients having a antiplatelet prescription was a risk factor, and uncontrolled hypertension was another risk factor. Sorry. So looking at the hazard ratios, none of these are very high, so the risk is not very high, but these were statistically significant. And if we can control the anemia and uncontrolled hypertension by improving the anemia and managing the blood pressure, there was a 19% reduction in the 1-year bleeding probability. If we can get rid of all 4 risk factors, alcohol abuse, anemia, antiplatelets, and hypertension, the reduction was 23% at 1 year. This is reduction in the risk of bleeding. So if we have a patient who has cancer and is on anticoagulation for thrombosis, we should pay attention to these risk factors to try to control them to reduce the risk of bleeding. And this next one is a common scenario that we come across on consults. Patients with cancer in the brain, whether metastatic or primary brain tumors, whether they should be anticoagulated or not if they have a thrombotic event. And so this study looked at imaging predictors of intracranial, intracerebral hemorrhage in patients with brain tumors treated with anticoagulation. So they were looking for markers of small vessel, cerebral small vessel disease, and on brain MRI, and intratumoral siderosis are associated with spontaneous intracranial, intracerebral hemorrhage. So basically, they show that baseline MRI findings with intratumoral siderosis, cerebral microbleeds, and moderate to severe cerebral small vessel disease appear to be predictive of spontaneous intracerebral hemorrhage in brain tumor patients on anticoagulation. And it seems that the intratumoral siderosis was not statistically significant after adjusting for the cancer type. So this gives us a bit more tools to consider when we are asked that question of whether a patient with brain lesions and have clots can be safely anticoagulated. And this next one is looking at myeloproliferative neoplasms. and looking at the non-driver mutations and VTE and association with VTE. So the driver mutations are basically JAK2, NPL, and calreticulin. But this is looking at the other mutations. So the non-driver mutations, specifically TP53 and possibly NRAS, appear to influence VTE risk in MPN patients. As ASXL1 shows statistically significant association in univariate analysis, but not in the multivariate analysis. And JAK2 mutation status does not appear to further influence VTE risk in the presence of a non-driver mutation. So for those of us who see VTE patients and we get these NGS studies, then this may help us identify patients who are at higher risk for developing VTEs. And this one is looking at using apixaban, low-dose apixaban versus standard of care for secondary prevention in cirrhotic patients with chronic portal vein thrombosis. So another common consult question, whether patients with portal vein thrombosis should be anticoagulated or how should they be managed. And so this is looking at adult patients with non-malignant portal vein thrombosis who completed 3 to 6 months of standard anticoagulation, and then they were randomized to either continuing with VKA or reduced dose apixaban at 2.5 milligrams BID. And so the study showed that reduced dose apixaban was associated with lower rate of PVT, portal vein thrombosis recurrence or progression, and major bleeding compared to VKA in cirrhotic patients with chronic portal vein thrombosis. Survival was actually found to be better in the apixaban group. And so a reduced dose of apixaban appears to be safer and more effective option for secondary prevention in this particular patient population. And I think this is the last one. So this is looking at protein S deficiency during pregnancy. You guys may not know this, but in Asia, the most common inherited thrombophilia is actually not factor V Leiden, as that's mostly a Caucasian population. In East Asia, protein S deficiency seems to be the most common inherited defect. And it's rare, still rare, but it seems to be the most common defect found in Asian countries. And so this is a Chinese study looking at patients with protein S deficiency and who are pregnant, and whether giving low molecular weight heparin, either alone or in combination with aspirin, would improve outcome, pregnancy outcome. So the three groups were enoxaparin, 0.4 mils daily. I want to say that would be equivalent to 40 milligrams daily, with aspirin, 75 milligrams daily, versus aspirin alone versus no intervention. So this is 1:1:1 ratio. And everybody got enoxaparin in the post-operative setting. I'm sorry, postpartum setting for up to 6 weeks. And interestingly, they did not find any difference in the outcomes, either with the combination group or the monotherapy group, compared to no intervention. And so based on the study, the authors recommended that we do not need to routinely use low molecular weight prophylaxis or aspirin in pregnant patients with protein S deficiency. This is interesting. This is an interesting finding because protein S deficiency is expected to get worse as the pregnancy progresses. So this is counterintuitive. Yeah. Okay. Sorry, I still took up a lot of time.
No, you covered a lot of very interesting points. I mean, thank you, Dr. Shen. Ibrahim, we can start with your part.
Yeah, thanks, everyone. Thanks, Taha, and thanks, Yuman. I am not going to cover as many studies, so I guess that's good since we're a little pressed for time. Um, let's see if I can move the slides here. Okay. So I was going to focus on a couple of studies in ITP and in sickle cell disease that I think are important. Um, I think most of us are familiar with the current therapeutic approaches for ITP, with first line being corticosteroids and IVIG with a high failure rate, and then the use of TPO agonists and rituximab usually in the second line. Splenectomy has been relegated further back, in the last few years. And then, third line options, including other immunosuppressive drugs and combination therapies. Um, there's a lot of exciting work being done in ITP. I'm not going to cover all of these, but just to kind of go over, there's neonatal FC reception inhibition with an important phase 3 trial that's ongoing, T cell inhibition with sirolimus. I think some of us are aware of the use of proximal complement inhibitors like sutimlimab, and even newer complement inhibitors like iptacopan are being looked at, and then plasma cell-directed therapies. I wanted to talk about one particular agent, rilzabrutinib, which is an interesting drug. It's a BTK inhibitor, but it's reversible, and works in a couple of ways. It inhibits B cell activation, like all BTK inhibitors do, and it interrupts platelet phagocytosis. But interestingly, has a lot of anti-inflammatory effects as well. Um, it also has a pretty low systemic exposure and doesn't have a lot of off-target effects, especially the platelet inhibition. So this drug was specifically developed for patients with immune-mediated disorders. Um, these are older studies looking at rilzabrutinib and basically showing that it does not inhibit platelet aggregation, which is important. That's as you guys know, is a class effect in earlier BTK inhibitors. Um, and then in this particular study that was presented as an oral abstract at ASH, was a phase 3 study looking at rilzabrutinib in adult patients with persistent or chronic primary ITP. And these patients have had to have had IVIG or corticosteroids, but have lost response to those agents. And they had to have platelet counts of less than 30. They were also allowed to be on a concomitant corticosteroid or TPO agonist. They had two primary endpoints. They had one primary endpoint, which was a platelet count of above 50 um, for greater than equal to 2/3 of the last 12 weeks, in the absence of needing rescue therapy. Something that set it apart from most ITP trials is they had an earlier endpoint of looking at platelet response at week 13. And that also looks at if the platelet count is above 50 or if it's above 30 or and had doubled from baseline. And patients that were non-responders had the option of discontinuing at that point or proceeding with just an open label with rilzabrutinib alone. The groups between the placebo and rilzabrutinib were fairly equal. A significant number of these patients have had splenectomies as well, and most of the patients also had exposure to TPO agonists. The initial platelet response, it basically showed that 65% of the patients on the rilzabrutinib arm had an initial platelet response based on the parameters that we discussed earlier, versus 33% in the placebo group. The median time to platelet response was about 2 weeks in the treatment arm versus 50 days in the placebo group. And then durable platelet response, which was measured at week 25, about a quarter of the patients on the rilzabrutinib arm were able to sustain a durable response versus 0% in the placebo. And then this looks at basically both the people that ended up on the open label versus the ones that were in the double-blind group, and they had similar durable responses as well. So in summary, this particular trial was a chronic resistant ITP cohort. It showed, I think, pretty good initial response rates and durable response rates compared to the placebo. There was overall a decrease in need of rescue therapy and a decrease in bleeding. Although I don't have a slide on this, they were able to also show that there was significant improvement in fatigue in the BTK arm at week 13 and 25, even among patients that did not have a durable platelet response. There weren't very many adverse events, and fortunately, there were no BTK class effects, so there was no effect on platelet dysfunction and no arrhythmias on this drug. I wanted to briefly talk about a poster on obinutuzumab. I think some of us have been using this off-label for some immune platelet disorders. This was a single center retrospective study looking at obinutuzumab in patients with ITP, immune-mediated TTP, and autoimmune hemolytic anemia that were refractory or intolerant to rituximab. So they characterized the CR in ITP as a platelet count greater than 100 on 2 occasions, at least 7 days apart, and a partial response of a platelet count above 30. 5 ITP patients, all on low dose steroids, had received prior TPO receptor agonists. It's not a big study, but basically they were able to show that 3 patients developed a CR and 2 had a partial response that was sustained after 9 months of median follow-up. All of the patients were able to taper or withdraw TPO agonists, and there were very few major issues. 1 had a self-limited infusion reaction, and 3 developed minor infectious complications. Moving on to sickle cell, this was an important study that was a plenary looking at hydroxyurea in patients with SC disease. So this is so you guys know about SC disease. Patients tend to have a higher hemoglobin. They tend to have more effects on the kidneys and in the eyes, and tend to have pretty high viscosities. So this trial, called the PIVOT trial, was done in Ghana. It was a double-blinded, placebo-controlled phase 2 trial, and it had enrolled 200 patients, half of whom were adults and half children. They were placed on 20 milligrams per kilo of hydroxyurea versus placebo for 12 months. And there were 2 opportunities in the study for dose escalation and open label continuation if deemed safe. So the reason that Ghana was chosen as a site is they have a very high incidence of hemoglobin SC disease. It's the most prevalent type of sickle cell disease in Ghana. Whereas in the United States, about a quarter of patients with sickle cell disease have hemoglobin SC. The primary endpoints were mainly looking at dose-limiting toxicities, so cytopenias. There was also a concern about high hemoglobin, so we always worry about hyperviscosity in sickle cell if the hemoglobin rises, so that was something that they looked at carefully. Secondary effects were mainly laboratory findings like CBC, retic count, and hemoglobin quantification. And they also looked at sickle cell-related events and hospitalizations. They had an exploratory arm that looked at blood viscosity and ectocytometry to look at the effects of hydroxyurea in SC patients. So this is just the breakdown of the trial, the 200 patients we mentioned. I wanted to point out a couple of things. So they were expecting a rise in the hemoglobin and did not see it on the hydroxyurea arm, which was interesting. They did see changes in MCV and did see changes in fetal hemoglobin. There was evidence of cytopenias that developed, but most of these were grade 2. This is kind of a closer look at the dose-limiting toxicities. Adults were more likely to have toxicity than kids were, but again, these were all grade 2 and not clinically significant. This wasn't the primary endpoint and it wasn't powered for it, but they were able to show that there was a significant decrease in all clinical related events, vaso-occlusive pain, malaria, hospitalization, and any sickle cell related complications in the treatment arm compared to placebo. And then this was the exploratory arm that looked at basically the effects of hydroxyurea on sickling and deformability. These are looking at shear rates at venous levels of viscosity and arterial levels, and they were able to show improvements in patients that were on hydroxyurea. So in summary, this was a successful phase 2 trial that was conducted in Ghana for SC patients. They were able to show that a 20 milligram per kilo dose was associated with more dose-limited toxicity, but all patients were asymptomatic, and these were mild, transient, and reversible. There were measurable benefits observed in hematologic parameters. It was also associated with fewer clinical adverse events, although this was not powered for this and wasn't the primary endpoint. And it's leading to the proposal of a phase 3 trial for this study. So hydroxyurea appears to be an effective disease-modifying therapy for patients with hemoglobin SC.
Thank you again, Yuman and Ibrahim. I really enjoyed.
Thank you for the opportunity.
Thanks, everyone.